building a better Bay Area for a safe and secure future. This is ABC 7 News.
We will be able to deliver a few 100 million doses of vaccine by the end of 2020.
We will defeat the enemy. Why? Because winning matters.
Winning matters, and we will deliver.
We'll distribute vaccines accordingly to all of America simultaneously. We will make sure that there is equitable distribution.
Progress on a safe and effective vaccine cannot come soon enough. But once a vaccine gets a green light from the FDA, actually getting the vaccine out to the American public will pose yet another challenge.
The storage and transportation of the vaccine.
We have to keep the product very cold and shipped in very much sub-freezing temperatures. That's going to be a logistical challenge.
In just a matter of hours, one of the planes here behind me will take off empty for Michigan, and when it returns, it will be loaded with one of the first shipments of the COVID-19 vaccine, and that is just the beginning of the operation.
Bay Area counties are gearing up to receive thousands of Pfizer's COVID-19 vaccine.
City officials, Kaiser Permanente and Dignity Health unveiled a new vaccine hub at the Moscone Center.
The Levi Stadium site is expected to serve 5,000 people a day.
FEMA's plan is to open the first mass vaccination site in the Oakland Coliseum.
President Joe Biden has an ambitious plan aiming for 100 million shots in the first 100 days in office.
We're nowhere near close to where we need to be.
We are sobered and mindful of the scarcity that is the number of available vaccines. Nonetheless, we are not naive about our responsibility here in the state of California to move these vaccines out of the freezers and into people's arms.
We're now on track to have enough supply for 300 million Americans by the end of July. We've never failed, we stood together. If there's ever a time we need to stand together, it's now.
Thank you so much for joining us for this very special edition of ABC 7 News. I'm Kumasi Aaron.
And I'm Kate Larson. Instead of our 4 p.m. newscast, today we are going to spend an hour engaging experts and you in an ABC 7 virtual town hall. Today we are focused on the COVID-19 vaccine, something Kumasi and I and the entire ABC 7 team have dedicated months to covering as part of our efforts to build a better Bay Area.
This is an important 1-hour virtual town hall. It's airing on TV, on our connected TV apps, on abc7news.com, YouTube, and Facebook. And over the next hour, we are going to have a thorough conversation focused on questions from all of you, our viewers.
We're going to get to our fantastic group of panelists. They will be answering questions that you have been submitting. We have received more than 1,000 questions. Thank you so much for all of those. And you can also continue to comment online with more questions and concerns.
Dr. Arlene Brown with UCLA, who also leads a statewide coalition focused on how COVID impacts disproportionately affected populations, is on our panel, along with Dr. Louise Aronson, a UCSF doctor specializing in geriatrics. Dr. Aronson and Dr. Brown are members of California's Vaccine Drafting Guidelines Work Group.
And Dr. Reed Tuckson with Tuckson Health Connections, a consulting business focused on prevention, public health, and care delivery, and a face familiar to our ABC 7 News viewers, Dr. Alok Patel, ABC 7 special correspondent and physician, and Dr. Nadine Burke-Harris, the Surgeon General of California. Dr. Burke-Harris will be joining us for the first 15 minutes, and many of our first questions will be directed towards her as we just got some brand new information from the state today. That new information is this. Health and Human Services Secretary Dr. Mark Ghaly just announced that starting March 15th, many more Californians will be eligible to get vaccinated. Doctors will be given flexibility to use their clinical judgment to vaccinate people ages 16 to 64 with certain conditions that put them at risk for COVID complications or death. The list of those conditions includes cancer, pregnancy, heart disease, Down syndrome, severe obesity, type 2 diabetes, and immunocompromised conditions, among many others. The state estimates this adds another 4 to 6 million people to those who will be eligible to be vaccinated by mid-March, putting about half of the state's population in an eligibility tier. Dr. Burke-Harris, will the vaccine supply be large enough for that eligibility influx? And how do you reconcile this new group with essential workers in groups 1B and 1Z who still need the vaccine?
Those are great questions. Thank you so much for that. And what we know right now is that we are building a system in California that we hope to be limited only by supply. And while we're expanding eligibility to this group of people, we do want to recognize that supply is still limited, although it is increasing, week by week. And so we want to let folks know that, there's still going to be, it'll still take time to get an appointment, even if you're eligible. There's still limitations in accessibility. But it was very important for us to recognize the increased risk that these individuals are facing, increased risk of death if they do develop COVID. And for that reason, it was very important for us to respond to that risk by opening up eligibility.
Dr. Burke-Harris, what about someone who's an essential worker, say a food or agriculture worker who doesn't have an underlying health condition? Will they still be in a priority group in addition to this new group of folks who are immunocompromised? And then also, what about the third-party administrators, Kaiser and Blue Shield, who are expected to come online in the next week or two to oversee this entire operation? How will that fit in?
Well, you gave the example of a food or agricultural worker who's currently in Tier 1 of Phase 1B. And so those individuals, yes, will still be eligible to receive the vaccine right now. We know that California will be making that transition from an age and sector-based approach to a more straightforward age-based approach after we complete the Tier 1 of Phase 1B, which is where most of our counties are now. And so a food and ag worker, yes, would have access to the vaccine. And then following that, we're going to a more strictly age-based approach.
Do you mind if I ask a follow-up question to Dr. Burke-Harris?
Of course.
When I personally was looking at these new guidelines, it makes a lot of sense to me that we have a younger age group of people with underlying medical conditions. I'm already getting messages from Californians who are worried that their underlying medical condition may not be represented in this high-risk group. And my instinct tells me that there may be some discretion at the provider's level to say, hey, you're not in these listed disease categories, but you're still immunocompromised or you're still high risk. And so I just wanted to ask you, is there room for, a discretion at the physician level to say, this individual does need the vaccine and fits in this group? Or is there any worry about accountability there?
Yeah, well, we're asking providers to really recognize that given there is a limitation in supply, right, that to really prioritize those who are at highest risk and for those who have a slightly lower risk. And this is the work that Dr. Aronson and others on our drafting guidelines work group really dove into the data and looked at the risk stratification for these different health conditions. And so I think it's really crucial for providers really to exercise a fair amount of recognition of the scarce supply to ensure that those who are at highest risk are able to get access to the vaccine.
Yes. And speaking of access, I want to pose, I'm sorry, Dr. Aronson, you had a question there?
I was just going to acknowledge the difficulty of doing this if you're faced with your patient who is at high risk to focus on the highest risk. It's going to be hard for patients and it's going to be hard for clinicians. But the way we get through it is for all of us to prioritize the highest risk and to stay a little more patient longer, which is one of the hardest asks at this moment in history. But that's really what's needed to save the most lives and get us back on track economically.
Yes. I know a big question surrounding these new guidelines is accessibility, especially people who might have challenges. They might be homebound. They just might have issues actually getting this vaccine if they are dealing with any of the conditions that are on that list. So I want to pose this question. This is from Brittany Doyle with Wise Health.
There are people that are not connected to organizations, that are not connected to any sort of committee or task force, caregivers. They're basically living socially isolated. I want to ensure that there's efforts and strategies in place to reach those people. And it is going to take a collective effort. So that's just basically my concern and my questions is what does that look like? How are we going to make sure that those people are reached?
Dr. Burke-Harris?
I second that question.
Yeah. Is this something that you can address, Dr. Burke-Harris?
Absolutely. I'm happy to address that question because that's something that we've worked very, very hard on at the state level. So there are a number of different ways that the state is seeking to do outreach for vulnerable or hard to reach populations. And number one, that starts with good old fashioned media, shouting it from the rooftops, getting it out there through social media. We have a public education campaign that's available in multiple languages to let people know and to raise awareness. We also, as you all may have heard, are rolling out across the state the My Turn system so that folks can either go online at myturn.ca.gov or call in to the phone line to be able to find out when they're eligible and get a notification at the time that they're eligible, or if they're eligible now to go ahead and make an appointment. But we also recognize that for some communities, that just raising awareness or public awareness isn't going to be enough. And that's why the state of California just granted $17.3 million worth of grants to community-based organizations. These are organizations that have been doing the work of doing the hard work on the ground of reaching out to our vulnerable communities, to our hard to reach communities. And we actually utilize the same infrastructure that we used for the census. So we worked with many of these community-based organizations for the census, where we were literally trying to count every person. Well, our hope is that we can vaccinate every person. And so utilizing that same infrastructure, we're partnering with community-based organizations who are trusted messengers, who have trusted relationships to do that outreach and engagement for individuals who may be harder to reach.
Thank you so much, Dr. Burke-Harris. We also have another question from John Jacobo with San Francisco's Latino Task Force, again about equity and sort of questions about the opacity of data available about these at-risk communities and just in general.
Our concern is that Latinos are not getting the equitable amount of vaccine that they should be getting, given the amount of infections we've seen, which we know here in San Francisco, at its peak, we were 15 times more likely than any other ethnic group to have COVID-19. When should we expect to get data, and when should we expect to know that there is truly equity being pushed behind the vaccine rollout?
So a great question, and I know some new data has been released, at least here in San Francisco this week. But Dr. Burke-Harris, when can people in California expect some of these numbers to be widely released so we know exactly who's getting this vaccine and when, and how many more folks in these at-risk communities need to get it?
That's absolutely right. We've been looking at that data. We want to make that data public. So I'm gonna have to confirm, because I don't have the latest in front of me, but I believe that data was going live today. So this is very timely. If not today, it'll be likely early next week. But we're looking at the data around access to vaccine based on race and ethnicity. And one of the things that I want to highlight is that when we look at the first tier of eligibility, phase 1A, where we were prioritizing our healthcare workers so that we can shore up our healthcare infrastructure, make sure we're vaccinating the vaccinators, and then also those at the extremely, extremely high risk, residents of long-term care facilities. We recognize that inherent in that is our inequities, because the proportion of healthcare workers that look like me, or that look like our viewer who just asked that question is disproportionate. And so what we are seeing is that in this first round, where we are now as a state, is that there are fewer Black and brown folks, fewer folks of color, fewer vulnerable individuals who have been vaccinated. But we recognize that was the rationale for that was to shore up our healthcare infrastructure. And that if we don't do that, the result is excess deaths. And when we have excess deaths, the majority of those excess deaths, they tend to be those who are more affected, our Black and brown communities. So it's a little counterintuitive, but the next piece of the work that we have to do as we move through our age-based tiers, and then as we move as we complete tier 1 of phase 1B, which is a combination of age and sector, what we have the opportunity to do now is use allocation to guide as one part of our equity strategy. And that is what we're working on now. We hope to have information to share with you shortly, but it's really around how do we direct more vaccine to our communities that are more vulnerable.
Dr. Burke-Harris, I have open side by side with the Zoom window, the 5-point plan for vaccination equity. And I think it really outlines what you were just mentioning, and 2 things on it about community partners and public education. I just wanted to ask you, do you think, in addition to just getting the actual doses of vaccines to these vulnerable communities, will this also address the vaccine hesitancy that we've seen in colored communities, underrepresented communities, with immigrants, and people just who may not necessarily trust what they're hearing? Are we going to be able to really reach them?
So I just allocation of vaccine alone is not going to get over vaccine hesitancy. I think that some of our strategies of working with community-based organizations, trusted messengers, and trusted providers, right? So, before coming into the state, I spent my career as the founder and a pediatrician in a community-based organization in the Bayview Hunters Point neighborhood of San Francisco. And it takes years to build that trust. People have to see that you're there. And that's why we as a state need to partner with our federally qualified health centers, with our community-based health centers, so that folks can go to their provider that they trust, that has been caring for them or their families for years, because they may not get it because Dr. Nadine Burke-Harris, Surgeon General of California, tells them to get it, but they may get it because their promotora suggests that they get it, right? Or someone who they've been working with and caring for their family. So I think that part of working with trusted providers and trusted messengers is critically important. And one of the other things that I also think is critically important is that we already know that it's going to take more work. It's going to take more time. It's going to take more resources to get equitable vaccination rates in vulnerable communities, because the reason for that hesitancy is because of years of de facto and de jure segregation, years of structural inequities that, frankly, even today, many people of color, many people in vulnerable communities find themselves going to the doctor and feel like sometimes they're not heard, right? Sometimes their interests aren't represented. So we have a lot of work to do. I think oftentimes we talk about hesitancy like, oh, those people, they don't trust the vaccine, when really we recognize, we have a lot of work to do to repair some of the historical harms that have taken place so that folks can trust in our healthcare system.
Well, Dr. Burke-Harris, thank you so much for your time today. We appreciate your conversation with us. This is just the beginning. We have much more ahead, including more of your questions, and we'll be right back.
And we want you to join in on the conversation. You are part of this ABC7 Town Hall too. You can go to Facebook or YouTube to weigh in and interact in today's virtual town hall, and stick with us online. Well, thank you, panelists. This has been a really interesting conversation already, especially with this breaking news that we just heard about an hour or so ago. So I'm curious what you all think of that. Folks who are between 16 and 64, starting March 15th, can get vaccinated with this list of serious underlying health conditions and disabilities. I know some of you, Dr. Aronson and Dr. Brown, were involved in the vaccine work group that I think was part of this conversation. Whoever wants to jump in, go for it. Dr. Brown?
Yeah, sure. I was deferring to her, having already spoken.
Deferring to you. So I will say that we think this is incredibly important. There are groups of people with serious mental illness, with other underlying chronic conditions who are at very, very high risk of death or serious complications if they get COVID. So the working group felt very strongly, reviewing the literature very closely, that it was incredibly important that we incorporate these groups into a high tier and get them access to the vaccine early on. We know that this will have huge implications for our hospital systems, for our population. And I'm happy to have Dr. Aronson add to that as well.
Yeah, I just want to make clear to everybody that we reviewed a ton of data to pick the groups. You can't ever do this perfectly because there are so many different conditions, but we really did map it out based on all the best literature, and we had people sending studies to each other, at midnight and 4 a.m. And we really made an effort to do this well. It is something that most other states are doing too, because it really is about saving the most lives and helping the people most vulnerable. In other words, most likely to get critically ill or die. And for the same reasons that age is the priority, these are other high-risk people, so including them just made sense.
And you provided the perfect segue to Dr. Tuckson, who I wanted to bring in here. And Dr. Tuckson, I'm curious what you think, since you're not in California. What do you think of this decision by California to include these high-risk condition folks who may be a younger age into our vaccine group, which it's been hard to get vaccines to folks here in the state?
First of all, I was on the National Academy of Medicine committee that made the first allocation framework designs. And we emphasized there that people with multiple chronic conditions and serious illnesses needed to be very high in the list. And I think the diseases that these scholars have chosen make sense. I will say, however, there's got to be great caution in how this gets implemented. We are seeing enormous numbers of people around the country who are breaking ranks, people who are not eligible, pushing their way into the line because they are privileged and have money. And so I want to be very hopeful that the management and the review system will weed out those who are gaming the system and using this wonderful intervention inappropriately.
Thank you so much. We're going to switch over to our TV broadcast here in just a few seconds.
I think that point bears repeating.
Welcome back, everyone, for our vaccine town hall. We want to get to a question now that we got from Rose, who we believe works with disabled individuals. And she wrote this question to us. If we wait for our vaccination slot, will we have had to delay our health care for a year and a half? Where can we go for the vaccine now? And this question, I think, really has two important parts to it. First of all, it's about vaccine access, but also what to do if you have been delaying care, but you're not eligible for the vaccine yet, or maybe you won't be able to get it until March. So I want to pose this question to our panel, and let's start with you, Dr. Brown. What would you say to Rose?
Well, I think that's a great question, Rose, and it's something that my patients ask me all the time, and I tell them, do not delay care. If you need care, you can get it. It's really important to recognize that we now have many, many ways to access care there, in addition to in-person care. So there are times you will need to come into an office, but our offices are now so much safer, I think, than they ever were. And we're taking incredible precautions, hand washing, social distancing, wearing masks, and in some cases, masks. So I think it's important to recognize that our clinics are very, very, very safe. And if you need care, you should definitely go in and get it. But we also now are using telemedicine in a way that I think none of us anticipated a year ago. And so we've got virtual visits via Zoom in some cases. We have telephone visits. So it's really incumbent upon your healthcare providers and your caregivers out there to make sure that you're encouraging people, particularly those who are disabled and may need help access care, helping them to get the care that they need. In terms of the second question, how do you find out when it's your turn to get the vaccine? California launched the My Turn website, and there's also an 800 number associated with it. And that site takes information from the caller or the person who logs in, and it provides information on whether you're eligible to get a vaccine now and where you could get it. But it also indicates people who aren't currently eligible, it takes your information. It will send out a call or a message indicating when it's your turn to get the vaccine.
Thank you so much for that, Dr. Brown. And I also want to loop in Dr. Tuckson here. I'm curious what you think in terms of access, how California has been doing in terms of the folks who need it most, and also how the whole country is doing, since you have a bird's eye perspective.
Well, the challenge is really across the country that we are struggling as a nation to be able to have enough supply to meet the demand. I would say that all of you who are frustrated, you are in a very big club. Everywhere we go in this country, people are lining up for the vaccine and are being told that they've run out of supply, or people have tried to make appointments and couldn't get an appointment in time. And so I think we all have to understand that this is a challenge that is upon us, but that we have to stay calm. We know the good news is that people want it, and that's really important. And I would also emphasize that we have been very concerned about people of color having higher rates of vaccine hesitancy or non-acceptance than other parts. Yet all around the country, as I look, African Americans and other people of color are in lines trying to get vaccinated and can't, or trying to make appointments and can't. So let's remember that the Biden-Harris administration is in place. They are working their tails off. There was good news announced today by the president about more doses. I think that we just have to stay calm, work with our local officials, and we will get there. But let's be also, as I conclude this answer, let us remember one clear thing. While we are waiting for our turn, and let's don't try to game the system and jump in line, and let's don't have the privilege taking away from those who are most in need while we have short supplies, everybody has to continue to be vigilant. Wear your mask, physical distancing, all the things that we have known we should be doing. This is the time, and I'm sure you're going to ask it later, but because of these variants in the virus, this is an absolutely essential time that while we're waiting to be vaccinated, we must follow public health guidance.
Yes, Dr. Tuckson, my next question is actually about the variants, and this one comes from Wallace Fung, who is with the Community Youth Center of San Francisco.
People actually have been expressing the concern, saying that, oh, after a few months, if they still don't get vaccinated, the virus probably will have been mutated like 3 to 4 times, right? Will the vaccine still work by then, right? And for those who have already been vaccinated, if the vaccine don't work against the new variants, does that mean they will have to be vaccinated again in the future?
Dr. Patel, I'm going to let you handle this because I know there's a lot of concern about the variants and how this ties into getting the vaccine.
There really is. And I think, I hate to say it, but I think some of it comes from these headlines, which are very scary. And sometimes people don't take the time to actually look at the underlying data and understand that, yes, variants are coming. RNA viruses, which this coronavirus is an example, that mutates every single month. And it's totally possible that it can mutate to a point where it's able to have a little bit more defense against our immune system, or the vaccines may not be as effective. But here's the really important thing. So far, vaccine manufacturers feel that the vaccines are still effective against the variants that we're seeing right now in the United States. Now, some people out there saw that data from the Johnson & Johnson trial and said, hey, whoa, 57% in South Africa. We now have that variant, B.1.351, in the United States. That's concerning. But the important thing is that the data also show that it was very successful, above 80%, at preventing severe infections, mild and severe infections, hospitalizations, and deaths. And that's key. And one way to think about that is with the annual flu shot. If you get the flu vaccine and you still get influenza, you're less likely to get hospitalized or wind up in the ICU. And that's really important for people to understand. You know, the United States and scientists and researchers are doing their part in genomic sequencing and looking at all the variants out there and making sure that the vaccines still work and we're spotting outbreaks. But I just have to echo what Dr. Tuckson just said. While we are doing our part, getting vaccines, and scientists look for variants, we have to all remember, if we let the virus replicate, it's going to mutate. And so it's not only important for all of us to take the necessary precautions, it's also really important to make sure we have vaccine diplomacy and we have resource poor areas getting vaccines as well, because you cannot have wealthy counties or wealthy nations hogging all the vaccines and then leaving it to replicate elsewhere. And I'm about to go on a soapbox, so I'm going to cut myself off.
I think that also Dr. Patel has really nailed that first part of that question. There's an important other part to it, and that is, will these vaccines, how long will they hold up? And will, as things change over time, will there need to be some changes? The answer to that is that we are really having to study that and really think hard and watch carefully. It may well be that our vaccines eventually will need a booster shot or a second dose. And there's a lot more that we have to learn. So I would urge you to know that we don't always have all of the answers right when we need to have them. There is still studying that is going on, clinical trials still ongoing. But for now, I think Dr. Patel really nailed it, that we think that we'll get people vaccinated in time while the vaccines are still effective, even against the three variants that are moving into the United States. And we will learn whether or not there needs to be a booster shot down the road, a year, 2 years from now. We'll find out more about that and deal with that as the science comes in. A little too early to answer the question definitively.
Yeah, definitely tough. I know a lot of people want answers to those questions right now, but sometimes we just have to wait and do that research and wait for the data to come back. I'm enjoying this conversation. So glad that we've been able to ask so many of your questions, and we are not done. We have much more ahead. If you have any questions, feel free to send them to us now on social media, and we'll be right back.
Don't forget you're part of this ABC7 Listens Town Hall too. You can go to our Facebook or YouTube page to weigh in, which is where we are now. I think we've got our panel here again to continue answering some of our very important questions to our online viewers. I thought that was a really interesting discussion about the variants and sort of this race between vaccinating people or changing our behavior through mask wearing, distancing, all the things we've been talking about for so long, and these emerging variants. What can you guys say about this race? What is our timeline right now? Is that even a question that's possible to answer at this point? Because we are seeing these variants emerge faster and faster. I think we've had a dozen variants emerge here in California. I know it's thought that one was responsible for the outbreak down in Southern California.
Well, I think, Dr. Patel said that this sort of virus mutates really frequently. So the question isn't, how many variants we have. It's sort of what do the variants do? Do they transmit more easily? Do they make you more likely to get severe disease? And some of this, we don't really know, but we do know some really important things, which is the vaccines do prevent the most serious disease. And people think, well, if it's not going to keep me from getting it, why should I get the vaccine? Well, I'm a geriatrician, and we save tens of thousands of lives each year with flu shots. People sometimes still get flu. It's only 56% effective, and we have many other vaccines, particularly most of the childhood ones, where we require boosters. None of this is different. None of this means the vaccine isn't effective. And with the flu, actually, we have a different vaccine every year because we get different strains, so there is precedent for all of this, and there are good people working on it. And really, it's humans are not comfortable with uncertainty. So this, makes us all feel uncomfortable. And we know how to prevent transmission and keep people safe with the public health measures, and the vaccines are coming more quickly. And those are really positive changes, things that we didn't know before. And our distribution methods are also scaling up and getting better. So yes, it's all new, but it's improving and improving week upon week.
It's really interesting because the flu vaccine, like Dr. Aronson mentioned, has to be updated or tweaked every year. Whereas the measles vaccine has been unchanged since the mid-60s. And so it's really interesting, and it's hard to predict which direction these viruses go and if they're able to evade the vaccine or not.
Well, and we only have a few more seconds left, and this might be a larger question, but at what point do you stop using a vaccine because efficacy drops? I know South Africa paused with the AstraZeneca vaccine. So I also believe in the health community and the scientific community, you're weighing these options. When do we proceed with a vaccine? When do we pull it back? When do we adjust?
15.
In the seconds left, it's certainly too early to worry about that right now.
Thank you so much, Dr. Tuckson.
Very efficient answer.
Love it. And true. Dr. Tuckson also wins the battle.
Well, Welcome back, everyone, to our virtual town hall on COVID-19 and the vaccines. We've gotten a question in on Facebook from Alex Kahuna, basically asking, is it really safe for a cancer patient to take this COVID-19 vaccine with all the meds that they're taking? This is in response to the new guidelines that list certain medical conditions that would now be prioritized in March under the new state guidelines. And this question kind of ties into a question that we're getting from Brittany Doyle, who's the owner and managing director of Wise Health, a group that's focused on addressing public health issues here in the Bay Area.
There's also been discussion around coexisting diseases that are embedded in the community. Will that have an impact with the vaccination? So if somebody has chronic disease like diabetes or COPD, where their immune system is already compromised, will the vaccination, affect their health as well?
And I want to pose this question to you, Dr. Brown. What would you say? I'm sure you're getting this question a lot from your patients.
Absolutely. And it's an excellent question. I think we know that the vaccine works in people with many chronic conditions because they actually tried to include people with diabetes and hypertension and asthma because they knew that these were the people at highest risk from the disease. So it's been well tested in people with many chronic conditions. We don't know about certain conditions because there may have been certain exclusions that differed from vaccine to vaccine. But based on the evidence we have and the evidence that from the trials and the evidence that's emerging from across the world, it is very safe for people with cancer, with other chronic conditions to take the vaccine. And you should definitely talk to your physicians, your cancer specialists, your general doctor before making any decisions if you are concerned. But it's really critical to recognize that this vaccine is very safe. And all the vaccines that we have to date are very safe for COVID-19. And they actually prevent both severe illness and hospitalizations and death. So it's in the hour that we're going to have here, we're going to have 100 people die from COVID, and and the vaccine we know has prevented millions of severe, so really bad outcomes for the people who have taken it so far. So we really support you doing that, taking the vaccine.
But I would piggyback on this. I'm sorry. No, go ahead, please, Doctor.
I was just going to use the exact same phrase, actually, to piggyback and to say that when people are concerned that their condition means they shouldn't get the vaccine, what I'm seeing is that usually means they are precisely the people who will benefit most from the vaccine. So the condition that is making you concerned is the condition that puts you at very high risk for serious disease, intensive care unit, and death. Everything we know, as Dr. Brown says, is that this is very safe and effective. And even if your immune system compromise is such that it's slightly less effective, these vaccines are so effective that slightly less is still really, really good.
And I'm so glad you went first, Dr. Aronson, but I would just want to add very quickly that this is one of the reasons why it is so important for people to participate in clinical trials. Those people who have these kinds of conditions, we are desperate for you to be a part of the clinical research apparatus. We are lucky that as you've heard from both of these answers, that there were sufficient numbers of people with chronic conditions and the challenges that we've heard, that we can be able to make a very well-founded argument that says you should. The data tells us that it is okay for you to be vaccinated. But the only reason why we know that is because of the generosity of people with those conditions who participated in the clinical trials. So we hope that everyone will learn from this and participate when you have the opportunity to do so.
Well, and doctors, there's clearly a lot of folks out there who are very at risk for severe COVID disease, including our older community members. And Brian writes in, he says, my wife and I are 90 and we have no computer. How can we get the vaccine? This is another access question. There's so many folks, maybe older folks, who don't have helpers, who don't have family members who can get on the phone or get on the computer and sign them up for all these appointments, which are difficult for the most technologically capable people. So how can we make sure this vaccine is accessible to folks easily? Dr. Aronson, since you are a geriatrician, I'd love to know what you think some of our older viewers can do.
Yeah, it's actually been on the one hand, amazing how we've ramped up all these centers, but also slightly disappointing that so many of them lack chairs for people to sit in. Or they'll say, you know, this place is really easy to get to, but many people have retired from driving, aren't safe on the buses, are not going to get in somebody else's car. So what Dr. Burke-Harris was talking about of the community-based strategy and using community-based organizations is working really well. I know there are a bunch of them in Southern California that have already done this. I think any vaccine dissemination plan, even if it's going to be primarily digital, needs a robust multilingual phone option available at all times. And any flyers that go out need to have a phone number listed prominently because people are going to have questions about how do they get places. At UCSF, we found that we actually had to provide transportation for some people over age 75. With some groups, we've also found that going to places where there are lots of seniors really helps. If you're not in that category, but have kept yourself safe and might accompany someone, I've also seen online young people just walking across the street to older neighbors and saying, hey, can I help you sign up? There's so many ways we can all be a part of making this better.
And I have a comment which may turn into another question for Dr. Aronson. But, you know, we were just talking earlier on the news about Massachusetts piloting a buddy vaccination program. So if anyone were a caretaker and were to take someone above the age of 75 to go get, you know, his or her vaccine, they would also be eligible for a vaccine. Now, given how many people out there desperately want to get one, in theory, it sounds awesome. And I know that this probably would run into some bottleneck with supply, but my co-panelists, do you think this would be feasible in California or other states?
Absolutely. I would say that we're seeing some really innovative strategies being deployed across the state. As Dr. Aronson mentioned at UCSF, there are several programs down here in Southern California. We have Kedron Community Hospital that has done outreach to senior living facilities and assisted living facilities in their area and pre-registered seniors to come in for the vaccine. And when they get there, they're expedited. So we recognize that these are folks who are at highest risk. They've been, in some cases, isolated for months, and we want to keep them safe. So let's get them vaccinated. Let's do it quickly. They're actually deploying a whole cadre of UCLA undergraduates to help with this process. So I think we, as Dr. Aronson so nicely stated, it's really imperative for us to kind of think outside the box and think collaboratively. How do we help our neighbors? How do we help the people who we don't know, who need our help? And I think that's where the community-based organizations and those strategies that they've deployed successfully for decades come into play. So it's really reaching out to the community and reaching out to the groups that actually know how to reach these communities, including the churches, the senior centers, the local primary and secondary schools. There's so many groups that can help and that can provide the services in language. That's really critical.
Well, and with so much discussion about vaccine, and this is a vaccine town hall, of course, but there's still testing and there's these emerging variants, so testing is still very important. So we have another question from John Jacobo, the health committee chair of the Latino Task Force in San Francisco, who's wondering about this.
Through the Latino Task Force, we run numerous testing sites here in the city and county of San Francisco. And we also just launched our first in-community vaccination clinic. The one concern we have is we've kind of noticed a trend throughout the city where we've seen a drop in how many people are coming to get COVID tests, to the point where at one site we were up to about 500 tests per day, and it's dropped closer to 200. Can we explain why it's important to still get tested and what the cadence should be for people to actually get tested, even though a vaccine has arrived?
I think we all have only so much space in our brains, and so much of our focus and attention right now is on getting vaccinated. So I wonder if that's contributing to lower testing rates. Dr. Patel, what do you think?
I think there's probably, it's multifactorial. So I think a lot of people are thinking about vaccination. There may be a false sense of security. And this is just my anecdotal evidence I've heard from people saying, oh, you know, trends are going down, our case positivity rate, our case rate are all decreasing. And there may be less urgency for people to go and get tested. But I think what's really important, especially as we're trying to monitor variants, is people who have exposures still need to go and get tested so that they can self-isolate and we can prevent further outbreaks. You know, we use so many different analogies to describe where we are. I like to think of it as we're in the second half of a marathon and we just have to finish it. We can't stop right now and let the pandemic catch up to us. We're in a race right now between variants and outbreaks and trying to get ourselves to herd immunity.
All right. Thank you, Dr. Patel. You talked about this false sense of security. I think this kind of ties into this question of people are having about what can I safely do at this point? And we got an email from Miss V, and she said, when we have both vaccines, how soon will we be able to travel? Will we still have to have a negative COVID test to fly? And it kind of ties into this question that we also got from Dawn, which says, after getting the vaccine, will I still be a carrier and have a chance to infect someone else? So I think a lot of people are excited about this vaccine, but still kind of curious as to what is safe to do because we don't want to continue to spread this. So I don't know, all of you could probably address this, but Dr. Patel, what are you telling people who have these questions about what can I do safely to not spread COVID, even if I have this vaccine?
And I'll be quick, just so one of the other panelists can jump in too, because there's a lot of information out there. As of right now, we're still waiting to see definitive data about how much these vaccines can reduce transmission. The vaccine trials were about preventing symptomatic illness, which is still really important. We got to keep people from getting sick and overburdening our hospital system. But we're still waiting to see how much it can actually prevent that person-to-person transmission, which is why it's still really important for people after they get their vaccine to still do everything they can to protect people around them, including wearing masks, distancing, and all of that. Now, there was some early data from the AstraZeneca vaccine that showed that people after getting the shot, their PCR samples were actually going down and they were carrying less of virus. And it's totally feasible that we're going to find out that these vaccines are not only giving us this protective immunity, but are actually sterilizing immunity. They're preventing the virus from actually spreading around, which would be a great thing to find out. So I think people just need to stay tight and sit tight and do the safe thing until we learn more.
I think that's extremely important. And again, just to re-emphasize it, that the vaccine, as far as we know today, does not prevent the spread from one person to another. I hope that we will learn that it does, but we don't have that data now. That means that we believe that you can be vaccinated well and protected from becoming significantly ill or dying, but still transmit this virus to other people. Until we get to what is called herd immunity, and you've heard that word before, this idea of having enough people in the population who are immunized so that there is no more fuel for this fire to burn. There are no more logs to put on the fire. It's already done and the fire burns itself out. That's about 80% of the population. So just think about where we are today and where we have to get to 80%. That's going to be a while. So you have to know that this is not a magic single bullet that all of a sudden you are immune and you can go do whatever you want to do. And also remember this, as you're thinking about traveling, you're traveling to other states or other countries where there may be different strains and different levels of risk. You don't know that. So you are going to need to be cautious for a while. And I think we realize that maybe hopefully after the summer into the early fall, things will have gotten to a place where life can certainly resume to be more normal. But the one thing is, if we don't follow the rules, we're not going to get to the finish line because the finish line is going to keep moving back.
I know a lot of people also have questions about kids, and this is another question from Brittany Doyle with Wise Health about that.
Why are children excluded from the vaccine? And what's the strategy to vaccinate children?
And let's start with you, Dr. Brown. What would you say to someone who's worried about their children and the plan to get them this vaccine?
Well, I was hoping you would go to the pediatrician, but I will tell you that, the vaccine tests, the trials, for the most part, did not include children. So one of the vaccine trials included children 16 and above. There are some ongoing studies now with children 12 and older, but because we don't have great evidence in children, the ACIP, that is a decision-making body for the country on everything related to vaccines, basically gave priority to adults and said, until we get better evidence for the Pfizer vaccine at 16 and older, and for the Moderna vaccine at 16 and older, and Pfizer it's 18 and older. And I defer to Dr. Patel, who I know has a lot of knowledge about these issues.
I have some knowledge, but I also get a lot of questions from anxious and worried parents, teens and kids about this as well. And, Dr. Brown's on point with the fact that we didn't have the data to actually definitively say, hey, if this was proven effective and safe and people above the age of 16, we can just give it to younger kids as well, because, children, against the misnomer, are not just little adults, and adults are not just big children. And, our bodies react differently to different medications, vaccines being one of them. And we may totally find out that younger kids, the kids in trials right now, age 12 or even younger, may require a different dose of the vaccine. Our immune responses are also different. In some vaccines, children have a different level of vaccine reactogenicity, may react differently to the vaccine as well. In the same way, they responded differently when they got COVID-19, and they weren't getting the same level of acute severe symptoms, but they were coming up with these delayed inflammatory responses, which kind of gave scientists a pause and say, well, maybe we shouldn't generalize them with the vaccine either. I think there's some early estimates that we may see some data about kids 12 and up by summertime. And I know there's a lot of people out there that want to see that data before the fall school year, and I am one of them.
I think
Can
we
I just
all would
jump
like
in
to
on that as the geriatrician. So there are three main physiologic life phases. There's childhood, adulthood, and elderhood. Now these trials, this has just been new in recent years, included people up to, in Moderna, age 85. Note, though, that we started vaccinating people in long-term care facilities who are often older than 85, sometimes 20 and 25 years older than 85, which some people might find shocking. But now as a geriatrician, I often deal with two generations of patients. We often don't include those people in trials, and they have different responses. Indeed, if you look on the CDC website, you will find the different reactions in children to the virus. You will not still find, despite an extensive evidence base, the different presentations in older adults. So I think this is also an opportunity to think about, yes, we are more vulnerable at both ends of the lifespan. But when we're studying something that matters to all humans, we need to include humans of all backgrounds and all ages in those trials, because history has shown that when we do not and then apply the results to those people, we often do them harm.
Dr. Aronson, I want to pose this question to you. This is from Wallace Fong, a program coordinator with Community Youth Center of San Francisco. He's actually told us that he's been getting a lot of questions about the impact for older individuals.
Could someone be too old to get to receive the vaccines? Because they have heard a lot of myths and rumors saying that there are a lot of different kind of side effects. So they're not sure if their body would be able to hold up.
Yeah, there's a lot of people concerned. Am I too old? Am I better off just to not get it than to risk it? And then my body's like overloaded. What would you say?
It's such a good question. And the good news is that what we are finding is that older people tolerate this vaccine very well. In fact, probably because of a phenomenon called immunosenescence, which is the immune system getting less strong as you get older. Older people tend to have less severe reactions to the vaccine than younger people. And by that, I even mean your average 50-something-year-old compared to your average 30-something-year-old. There is a range over the lifespan. So it appears to be perfectly safe. And given if you're quite old, your incredible risk of severe illness, death, or huge functional or cognitive losses from the virus, we are strongly encouraging this. And, sort of for better or worse, we haven't given vaccines to kids because we haven't studied them, but we have given vaccines to very old people, although we haven't studied them. And luckily, we found that they tolerate them well.
Panelists, I have one quick question for you for all of our older folks who have been able to get the vaccine and are maybe looking at their second vaccine, which can sometimes come with stronger side effects. What can people take? What type of over-the-counter medications are safe to take after a vaccine? And how many hours after the vaccine is it safe to take? Tylenol, ibuprofen, Advil? What are your thoughts? Dr. Brown, maybe you can answer.
Sure. I think I preface this by saying that you should definitely talk to your doctor about it, because you may have a reason for not being able to take one or more of these medications. But for many people, taking Tylenol a few hours after the vaccine is fine, or Advil, making sure you take it with food. But for people who are having side effects, sometimes that's helpful. And as Dr. Aronson said, a lot of times many of the people I'm seeing have not had very many side effects from that second dose. So the second dose is the place where we see more symptoms.
Perfect. Well, Dr. Brown, I'm sorry, we're going to have to answer this question in the break, because we're going to take a short pause here on TV and be right back with some final thoughts. But in the meantime, join us on Facebook to get the rest of that answer to that question.
But it's definitely Dr. Tuckson's turn.
Yes. My second Pfizer shot, by the way, knocked me out, and I was like, "It's immune reactogenicity. I'm okay with it." But yeah.
Well, my first
one was fevers.
I asked
this fevers, rigors, myalgias, chills. Yeah.
That's because you're young. I only had pain.
We're like,
there's some advantages to this hair. I earned it.
Well, and doctors, I heard from someone I know that they were told not to take any of the anti-inflammatories because that can have an adverse reaction to a vaccine, and to go ahead and take Tylenol, but do it at least 4 hours after your second shot, because somehow acetaminophen could also interfere with the immune response. So, a lot of people know what they wanted, they can do to sort of mitigate this pain and suffering after a vaccine if it happens.
Well, the point I was going to make, by the way, was whatever you do, don't take it before. That's the key thing, is that that's where the problem comes in, because we believe and we know from other vaccines that by taking these drugs on the front end can affect the vibrancy and the potency of the vaccine itself. That's the key thing we wanted to emphasize.
Well, thank you for explaining that, because I do know people who have pre-medicated, and now you can at least share with folks that that's not the way to go, to make sure that you're getting the most effect from the vaccines.
But I think there's an important asterisk, and this is not my patient population, but this would be, I think, a lot of adults, people with chronic disease, is that even though what Dr. Tuckson is the current recommendation and people shouldn't pre-medicate, if people are taking an anti-inflammatory, a steroid, or another immunosuppressant for a long-term medical condition, they should not stop their medications prior to getting a vaccine. So I think there's just a difference for the public to understand.
It's a great point.
Bottom line, check with your doctor, or can folks check with whoever's administering the vaccine? Because sometimes people don't always get it from their practitioner.
Absolutely. In most places, there will be a physician, a nurse practitioner, or physician's assistant at the vaccine site available to ask questions.
I love it. I know we talked about this a little bit. How long did you say?
1 minute.
Okay, briefly, we also have questions about people who are wondering if they get one specific type of the vaccine for their first dose. They're concerned about possibly getting another type for the second. I know last time we talked, they were like, you guys told us kind of just, keep it the same. Do you still feel that way, or has that thinking evolved as we've gone along this process?
30 seconds.
That recommendation stands.
Oh, please.
I was just saying that recommendation stands, that it's recommended that if you get one maker of the vaccine, you should take that same vaccine the second time. There are some studies ongoing to look at what happens when you do that switchover, but until we get the data, the recommendation is still that you get your second vaccine with the same, vaccine. That's
spot on.
Awesome.
Spot on.
All right, well, we're going to head back to TV in a couple of seconds. Thank you so much for joining us, everyone. We really appreciate that.
This has been a great conversation.
It's not AstraZeneca was in.
Welcome back, everyone. We just want to say thank you so much to our panel of experts for taking time of their busy schedules to talk with us today, and with all of you about the crucial questions surrounding the COVID-19 vaccines. It is a time for optimism, but in many ways, we have quite a ways to go in the fight against this pandemic.
Absolutely. Thank you so much to our panelists. And we are continuing to follow these important stories, and we'll keep you informed and connected to all sorts of great resources. You can find more on abc7news.com and on our connected TV app for your Roku, Apple TV, Amazon Fire, and Android TV. Thank you so much for joining us. Again, thank you to all our brilliant panelists. ABC7 News at 5 o'clock is coming up next.